Bismillah ar-Rahman ar-Rahim. Today we will start the lecture about cutaneous malignancies, presented by Dr. Mohammed plastic and reconstructive surgeon. Skin cancer, it is estimated to occur in about 1 in 5 Americans during their lifetime. So it will occur in about 20% of population in the United States. So it is a common type of cancer. There are main 3 different types. The first one called the basal cell carcinoma, which consists about 80% of all skin cancers. The second one, the cutaneous squamous cell carcinoma, which consists about 15 to 20%. And the last one is the malignant melanoma, which forms less than 5% of all skin cancer types. This is the example of basal cell carcinoma. This is the cutaneous squamous cell carcinoma. There are cutaneous and mucosal squamous cell carcinoma and the malignant melanoma. As we said, the basal cell carcinoma is the most frequent one. It is about 80% of all skin cancers, while cutaneous squamous cell carcinoma about 15%, and the least is the melanoma, malignant melanoma, of less than 5%. Risk factors. As any risk factor divided into environmental factors and host factor. The environmental factors like human papilloma virus, which cause common wart, sunlight exposure, mainly due to UVA and UVB light, smoking, the exposure to radiation and immunosuppression, also exposure to chemicals like arsenic and hydrocarbons, and chronic inflammation. For example, in chronic ulceration of the lower extremities due to venous ulcer or diabetic foot or any other injuries that resulted in chronic inflammation may increase the risk of squamous cell carcinoma. The host factor or patient factor. Male patient. Male usually develops skin cancer more risky than female. The advanced age also, and the skin type 1 or 2 according to Fitzpatrick classification. Fitzpatrick classification classifies skin into 6 types. The first one, like the Scottish population, they develop sun damage easily and never tan when exposed to the sunlight. Type 2 also develop easily sun damage and tan with difficulty. Type 3, like in our country, that tan easily when exposed to sunlight. Also, the resistance to sun is not like other types. For example, type 4 in Indian population, they resist the sunburn. Type 5, like in black African patient, also resist sun damage. And type 6, like in the black American population, who never tan and never get sun damage. So the risks in type 1 and type 2. Also positive family history of skin cancer, and it could be part of syndrome. For example, Gorlin syndrome, which is called basal cell nevus syndrome. These nevus, all of them are basal cell carcinoma. Histopathology. Regarding the basal cell carcinoma and squamous cell carcinoma, both of them arise from the basal layer of the epidermis. The edge of the tumor, if it ulcerates, differ in basal cell carcinoma than squamous cell carcinoma. In basal cell carcinoma, the edge called ruled border or raised edge. This occurs because of the central necrosis of a tumor cell occur while the tumor extends toward the periphery, causing the edge to be raised in the level compared to the margin. The ulcer described this area as the edge, and this part is the margin. While in squamous cell carcinoma, the growth is very rapid, that causes the edge of the tumor to rise and become overhanging over the margin of the lesion. This is the overhanging or everted edge. Here's an example of squamous cell carcinoma with everted edge. The metastatic rate in basal cell carcinoma is very rare. The maximum it may reach to about 0.05%, while in cutaneous squamous cell carcinoma it could reach as 14% metastatic rate. Basal cell carcinoma can be divided into different types according to its shape. The most common one is the nodular basal cell carcinoma, which is a dome-shaped nodule or papule with a pearly glistening surface, with a scattered telangiectasia, as we see. Typically, it ulcerates centrally, giving the classical rodent ulcer appearance. Other type is the superficial separating basal cell carcinoma, which is a multicentric, as we see, erythematous patch on the trunk and extremities. This type usually difficult to diagnose early because it is similar to the discoid lupus, to the tinea versicolor or psoriasis. So we should put in our mind the basal cell carcinoma, superficial separating one, in the differential diagnosis when we face such lesion in the trunk and extremities. Another type is called morpheoform or sclerosing basal cell carcinoma, which is the most aggressive type, usually found in elderly patient, mainly in the head, neck, usually in the scalp, in bald patient. The patient presents usually with a scar without any history of trauma. This scar is the morpheoform sclerosing basal cell carcinoma, which is aggressive type of basal cell carcinoma. The main characteristic, scar without history of trauma. Another variant, the infiltrative and micronodular. This is less common than other previous types, but considered of high risk and aggressive basal cell carcinoma. However, squamous cell carcinoma divided into mainly two types, the well-differentiated tumor type and the poorly differentiated. In well-differentiated tumor type, the tumor is firm. This is important, the tumor firm, with raised pink or flesh-colored papule with a frequent keratinization, scaling, ulceration, crustation on the surface. The main characteristic of well-differentiated type clinically is a firm nodule with crustation and scaly lesion, while the poorly differentiated one presents as a soft granulomatous nodule, granulation tissue, with areas of hemorrhage, necrosis, ulceration, and lack any keratinization. So when we see keratinized squamous cell carcinoma, this is well-differentiated type, better prognosis, while if we see lack of keratinization, we should think about poorly differentiated one. Diagnosis. Clinical examination may suggest the tumor type, for example, in the upper lip, usually basal cell carcinoma, while in the lower lip, usually squamous cell carcinoma. The explanation about the high risk of basal cell carcinoma in upper lip is due to a lot of number of hair follicles in the upper lip, while in the lower lip, the squamous cell carcinoma is more predominant because of the more exposure to sunlight compared to the upper lip. Tissue biopsy to confirm the diagnosis. Treatment. If the lesion is of low risk, we can go to non-surgical modalities called the destructive modalities. For example, the electrosurgery, electrodesiccation, or by using liquid nitrogen called cryosurgery. We frozen the tumor with the liquid nitrogen and leave the tumor to get necrosis and slough away. Another type is topical fluorouracil. This is a chemotherapy or immune stimulant like Aldara or Miquimod. Also, intralesional injection of interferon, radiation, and photodynamic therapy. All these destructive modalities can be applied in a low-risk basal cell carcinoma and in very selected low-risk squamous cell carcinoma. Definitive treatment is by surgical excisional modalities, which involve direct excisional biopsy with evaluation of the surgical margin to confirm the free of a tumor. If the tumor size is less than 1 centimeter in diameter, then we put a safe margin about 5 millimeter. But if the tumor dimension, the greatest diameter, more than 1 centimeter, we should go to 10 millimeters safe margin to ensure clearance from tumor cell. Another modality of surgical excision called the Mohs micrographic surgery. Mohs is a French dermatologist, invented this technique. He applied this technique in cases of high-risk basal cell carcinoma and in cases of complex area like in the tip of the nose or in the eyelid. There is a lot of skin that we can sacrifice to ensure the clear margin. So we go to Mohs micrographic surgery, which involve accurate removal of the tumor, then excise exactly at the same size of the lesion the remaining skin, taking this segment of skin, assessed in the lab to assess the clearance of the margin and the base. If it is clear, the surgery ended. Otherwise, the surgeon should go back to theater and take more from the margin or from the base according to the report of the pathologist. The last type of skin tumor is the malignant melanoma. It arises from the melanocyte of the epidermis. Despite it forms less than 5% of all skin cancers, which is the least common type of skin cancer, but it forms more than 75% of skin cancer death. So there is a mortality in malignant melanoma. Risk factor, also host factor, in patient with Fitzpatrick type 1 and type 2, in patient with blue and green eyes, and in cases of congenital melanocytic nevi, congenital nevi, and giant nevi. There is a tool to assess if there is indication to biopsy any pigmented skin lesion. Not every pigmented skin lesion is a risk of melanoma. We can depend on this tool to decide if we should do a biopsy of the lesion. If we see asymmetry, border irregularity, color variation, diameter more than 6 mm of this pigmented lesion, and if there is evolutional changes in the appearance of the lesion over time. Here we see the border is symmetric. If it is asymmetric, we should go for biopsy. The border is regular. Here's irregularity. The color is uniform, while the color here variation, different color in one lesion. Diameter less than 6 mm, diameter more than 6 mm. Evolutional changes like increase in the size, change in the texture, change in color, become multiple. All these indicate a biopsy to exclude melanoma. Types. The most common type is the superficial separating one. Usually it occurs in the trunk of men and in the legs of women at age of 30 to 50 years. It is a flat or slightly elevated. The other type, which is aggressive, called the nodular melanoma, which occur in the legs or trunks as elevated nodule, sometimes ulcerated. There is high incidence of lymph node involvement. Because of the vertical growth of this lesion, there will be high risk of lymph node involvement. Another type called lentigo-malignant melanoma, usually in elderly patient in a sun-damaged area on the scalp, head, and arms. Acral lentiginous, usually in African American, but also to occur in white people, usually presented with a nevus in the palm of or the sole of the foot or beneath the nail, called subungual melanoma. This is also an aggressive type of melanoma. There is high risk of lymph node metastasis. Another type called desmoplastic melanoma, usually in the head and neck as a nodule. There is low incidence of lymph node metastasis, and some authors describe this as a kind of sarcoma, not a melanoma, called desmoplastic melanoma. Diagnosis: we should go for full thickness excisional or incisional biopsy. There is no rule for shave excision. We should do full thickness to decide the thickness of the lesion, which will direct our treatment. Also, we should go to assess the lymph node by either imaging studies or clinical assessment and screening for metastasis using the imaging and laboratory test with the clinical evaluation of the patient. So we should take full thickness biopsy, lymph node assessment, and screening for metastasis. Treatment consists of wide and deep excision, together with regional lymph node management. What we mean by wide and what is the deep? Wide, as we said, according to the thickness of the lesion. If it is in situ, didn't extend beyond the basement membrane of epidermis, we can take 5 mm safe margin around the lesion. If it is less than 1 mm thickness of lesion, we can go to 1 cm safe margin. If it is 1 to 4 mm, we should take at least 2 cm safe margin. If it is greater than 4, we should go for 2 to 3 centimeters. The deep excision, we mean by the deep excision, we should go to the next layer. If it is in the skin of trunk or extremities, we should take the skin, subcutaneous tissue, and the underlying fascia, reaching to the next level, as seen in this figure. Full thickness skin, subcutaneous, and the deep fascia. If it is occur in the auricle, for example, we should take a wedge resection to take the underlying cartilage, which is close to the skin. If it occur in the digit, like in subungual melanoma, we should go to amputation. Amputation involving the middle phalanx, middle part of middle phalanx in the digit and toe, and in the proximal phalanx of the thumb or big toe. Regional lymph node treatment. If clinically we found enlarged lymph node, we should go for what's called lymphadenectomy, which is complete removal of the regional drainage lymph node. Example, if in the lower extremity we take the superficial deep inguinal lymph node and go to the para-aortic one. If clinically we couldn't find enlarged lymph node, we should go for sentinel lymph node biopsy. Sentinel lymph node biopsy involves the injection of the drainage basin with methylene blue, and radioisotopes, and traced to identify the first lymph node in the drainage basin. This lymph node excised, you can see in this figure, this lymph node excised and assessed if it is involved by the tumor cell. Then we should go for the lymphadenectomy, which involve entire regional lymph node basin drainage should be excised here in the regional inguinal lymph node, deep and superficial one, and go to the retroperitoneum to take the para-aortic lymph nodes. Thank you.